Welcome to Test Day Panic. Your exam is right around the corner, so we're diving straight in. No fluff.
Exactly. This is your high-speed review of critical maternal and newborn concepts. Let's hit those meds first.
Okay, go.
All right. Benzatropine, that's for extrapyramidal symptoms. Then butorphanol, key pain reliever, sedative, used often during labor. It's an opioid choice we see a lot.
Got it. Newborn meds?
Erythromycin ophthalmic ointment, that's prophylactic, prevents blindness from potential gonorrhea or chlamydia. And the hepatitis B vaccine, standard to prevent Hep B.
Right, and we need to mention heparin. It's an anticoagulant, but remember there's still a bleeding risk, pregnancy, and postpartum.
Absolutely. And then the big one, oxytocin. You have to know its dual role.
Sure.
Yes, inducing or augmenting labor.
But also critical postpartum.
Critically important, it prevents postpartum hemorrhage by making that uterus contract strongly. It's a lifesaver, frankly, given hemorrhage is still the top cause of maternal mortality.
Wow. Okay.
And lastly, vitamin K injection for the newborn. Jumpstarts their clotting factor since their gut isn't quite ready yet.
Okay, let's lock down intake terms. They love testing these. Gravida.
Total number of pregnancies. Includes the current one, and yes, count all miscarriages, doesn't matter when they happen.
Dear.
That's the number of pregnancies carried past 20 weeks.
Okay.
Again, outcome doesn't change the count.
Crucial distinction coming up. Pregnancy confirmation, home test.
Only probable,
Mhm.
not definitive proof for the exam.
So what is positive definitive proof?
Only two things count as positive signs: seeing the fetus on ultrasound and actually hearing verifiable fetal heart tones. That's it.
Good clarification. Moving to labs and safety.
Standard panel. CBC, STI screens, blood type, RH factor,
Yeah.
but flag the rubella titer.
Why is that one so critical?
Because if she's not immune, you cannot give the vaccine while she's pregnant. It's a live virus. It can cross the placenta. Big risk to the fetus.
Makes sense. And basic safety rules.
Obvious ones.
Hmm.
No alcohol, drugs, smoking.
Yeah.
But also specifically educate against hot tubs. They raise core body temp too much. Regular warm baths, fine.
What about pets?
Avoid cats, and especially cat litter. That's the toxoplasmosis risk.
And meds. Pain relief.
Super strict here. No NSAIDs, period. Tylenol is generally okay, but everything else needs a direct okay from the doctor. No guessing.
Got it. What about that lovely morning sickness, vomiting?
The classic advice works. Eat saltine crackers before getting out of bed. Seriously, before feet hit the floor.
Stabilizes blood sugar.
Exactly. Then small, frequent meals. Avoid greasy stuff. Ginger helps some people. Mint or lemon tea, too.
Okay, shifting gears. Second trimester. What's key here?
We start regular fundal height checks.
Yeah.
And this is when a lot of those lovely pregnancy symptoms really kick in.
Lovely, like
Heartburn, back pain, hemorrhoids. That intense round ligament pain, patients really feel that one. Sleep issues, insomnia, and polyuria, peeing all the time.
Yeah, it sounds like a fun list. But these are expected normal changes.
Right. Physiologically normal, even if uncomfortable. Now, third trimester, 35, 36 weeks, things get serious. Visits increase.
Focus on prep.
Yeah. And fetal well-being. Fetal movement counts. Remind patients babies sleep, but if movement seems less, try caffeine or sugar first. If still low, call back immediately. Don't wait.
And critical testing window here.
Absolutely critical. Test for group B strep at 35, 36 weeks.
Why is this timing important?
GBS is usually harmless to mom, but if she's positive, we must have antibiotics, usually penicillin, running during delivery. Prevents the baby getting it.
So the test result only impacts labor management.
Exactly. Doesn't mean treatment before labor, just during.
And RHO-GAM, let's clarify the timing on that.
Okay. If mom is Rh negative and dad is Rh positive or unknown, mom gets RhoGAM. It prevents her from making antibodies against a potentially Rh positive baby.
2 shots, right?
2 shots. First shot is during the third trimester, usually around 28 weeks. Second shot is given after delivery, but only if the baby is confirmed Rh positive.
Got it. How do we advise patients about contractions?
Braxton Hicks usually ease up if you move around. Real labor contractions, they need to call or come in if they're consistently 5 to 7 minutes apart and don't get better with movement.
And if their water breaks?
Call. Trickle or gush. Doesn't matter. If they think it broke, call.
Okay, intrapartum. They arrive. What's the intake process?
Vitals, of course, including fetal heart rate.
Yep.
Get the health history, review the birth plan if they have one.
Membranes rupture. What are we looking for in the fluid?
Clear is good. That's what we want. Deep red, obvious bleeding concern, but green or brown fluid, that's meconium.
Baby pooped in utero.
Right. High risk of meconium aspiration when the baby takes its first breath. That's dangerous.
Okay, then the cervical check. 3 components.
Yep. Dilation, how open, 0 to 10 centimeters. Effacement, how thin the cervix is, goes up to 100%. and station.
Station confuses people. How to remember it?
Think of the ischial spines as 0 station. Positive numbers mean the baby is further down, closer to delivery. Think positive progress. Negative numbers mean the baby is higher up, superior.
And fetal presentation. Best versus worst.
Best is cephalic, head down. Specifically, occiput anterior, that's the back of the baby's head towards the mom's front. Easiest delivery.
Worst.
Reach. Butt or foot first. Almost always means a C-section. Transverse, lying sideways, needs repositioning, often with Leopold's maneuvers. Oblique is also tricky. Risk of shoulder injury.
Okay, stage 1 labor. Break down the phases.
Latent phase, 0 to 3 centimeters. Contractions are usually mild.
Yeah.
Active phase, 4 to 7 centimeters. Baby starts descending more. Mom's anxiety often increases.
That transition.
8 to 10 centimeters. This is tough. Often see the bloody show. Intense rectal pressure. Moms can feel apprehensive, maybe hyperventilate. Pain relief is usually requested here, if not already started.
Speaking of pain relief, anesthesia consideration.
Big one is sudden hypotension. Watch that blood pressure after an epidural or spinal. And mom can't get out of bed until sensation fully returns.
Difference between epidural and spinal.
Epidural uses a catheter, allows for continuous infusion. Spinal is typically a one-time injection, good for C-sections or late labor.
Analgesics available.
Opioids like butorphanol, also nalbuphine, meperidine are common options.
Stage 2 from 10 centimeter to birth. Key instruction for mom.
Push only with contractions. Conserves energy, reduces tearing risk. This is when crowning happens, those cardinal movements of descent and rotation.
And episiotomy.
That's a physician-made incision to enlarge the opening, if needed. Not routine anymore.
Stage 3. Baby's out. What's next?
Placental delivery. Short stage, but critical. The team must check that delivered placenta is fully intact. No missing pieces.
Why is that so vital?
Retained fragments are a major cause of postpartum hemorrhage and infection. Got to make sure it's all out.
Okay, quick detour. Fetal circulation, umbilical cord basics.
Ideally, 2 arteries, 1 vein. Remember AVA. And counterintuitively, it's the vein carrying the oxygenated blood to the baby from the placenta. Arteries carry waste away.
And the shunts, the bypasses.
3 main ones. Ductus venosus bypasses the liver. Foramen ovale is a hole between the right and left atria, bypasses the lungs. Ductus arteriosus connects the pulmonary artery to the aorta, also bypassing the lungs.
What closes them?
Pressure changes at birth. That first breath dramatically changes pressure in the heart and lungs, causing the foramen ovale to functionally close almost immediately. The others close over hours or days.
Fetal heart rate strips on the exam. What's the key thing to look for?
Variability. Look at that top line, the FHR. You want to see those little jagged ups and downs, the hills and valleys. It shows the baby is well oxygenated and responding dynamically. Flat line is bad.
When is a C-section indicated?
Definitely for non-vertex presentations like breech or transverse. Also, if mom has an active herpes outbreak,
Incision types?
low transverse is preferred. Classical, the vertical one, makes future vaginal births much riskier because of how the uterus scars.
Induction. What drug?
Primary drug is oxytocin, brand name Pitocin. Given a free, stimulates uterine contractions. Needs very careful monitoring.
What if labor starts too early, preterm?
Magnesium sulfate. Relaxes the smooth muscle of the uterus to try and stop contractions. It's also the main treatment for preeclampsia to prevent seizures.
Magnesium needs careful watch, right?
Right. Extremely careful. Strict monitoring for toxicity, checking reflexes, respiratory rate, urine output.
And assisted delivery. Forceps, vacuum.
Methods of last resort.
Yeah.
Usually for maternal exhaustion or fetal distress, latent labor. They carry risks bruising, lacerations for both mom and baby.
Okay, transitioning. Baby's born, placenta's out. Stage 4, postpartum, first few hours. What are we watching?
Hemodynamics. Expect maybe slightly lower BP, slightly higher heart rate, thirst, maybe some shaking that's common. The absolute priority is the fundus check.
What if the fundus isn't midline?
First thought,
Yeah.
full bladder, do a bladder scan or help her empty it. A full bladder pushes the uterus out of place and stops it from contracting properly.
Which it leads to?
Hemorrhage, the #1 postpartum danger. Risk is higher after long labors if there were retained placental pieces or significant lacerations, and bladder distension makes any bleeding worse. Always check that bladder if the fundus is boggy or displaced.
You mentioned APGAR, guaranteed exam question.
Pretty much guaranteed. Know the components. Activity, muscle tone, pulse, heart rate, grimace, reflex irritability, appearance, skin color, respiration, breathing effort, scored at 1 in 5 minutes.
Let's run through the rest of the postpartum assessment. That BB-LIAS acronym is helpful.
Okay, B is for breast. First few days, expect colostrum thin, yellow. Engorgement happens when milk comes in, best relief. Feed more often, like every 2–3 hours, or pump just enough for comfort. Check for mastitis signs, heat, redness, pain, or clogged ducts, which feel like little nodules.
U is for uterus.
Fundal assessment is absolutely critical. Should feel firm, like a grapefruit, and be midline. It descends about 1 centimeter per day. Should be around the umbilicus 4 to 12 hours after birth.
What if it's boggy, soft, spongy?
Massage it immediately. That's the first nursing action. If massage doesn't firm it up quickly, notify the provider ASAP. She likely needs Pitocin or another uterotonic drug to prevent hemorrhage. Don't delay.
E2 bladder. We covered this, but reiterate.
If the uterus is boggy or off to the side, suspect a full bladder is displacing it. Get her to void. If you can't, a straight cath might be needed. Fixing the bladder often fixes the boggy uterus.
C3 bowels.
Expect first BM1-2 days after birth. Teach her not to strain, especially with stitches. Treat hemorrhoids, which Hazel pads, baths are good, and make sure she has stool softeners ordered.
Eloquia.
The discharge. It changes color. Rubra first. Bright red lasts 1 to 4 days. Then serosa, pinkish brown. Then alba, creamy white, can last 2–3 weeks.
When to worry.
If rubra lasts longer than a few days, or if it suddenly returns after being srosalba, tell patients, though, a sudden gush when standing up can be normal, just pooled blood releasing.
Episiotomy extremities.
Yeah.
Pain relief for stitching.
Key timing. Gold packs first 24–48 hours to reduce swelling and numb, then warm compresses or sitz baths after 48 hours to promote circulation and healing. Use the peri bottle for hygiene.
And extremities.
Assess for DVT, look for redness, swelling, pain in the legs. Prevention is key. Early ambulation, SCDs if needed. And importantly, do not perform home and sign. It's unreliable and potentially dangerous.
Finally, S psychological status. Big difference between the types.
Huge difference. Baby blues. Very common, usually mild sadness or mood swings, starts a few days postpartum, lasts less than 2 weeks, doesn't interfere with caring for baby or self, normal adjustment.
Then postpartum depression, PPD.
More severe. Symptoms last longer than 2 weeks, or they significantly affect her ability to function, ADLs, enjoy things, or bond with the baby. Insomnia, major mood swings, feeling hopeless, needs assessment and treatment.
And the most severe?
Postpartum psychosis. This is rare, but a psychiatric emergency. Can involve delusions, hallucinations, paranoia, high risk of self-harm or harm to the infant, infanticide. Requires immediate provider intervention and often hospitalization.
Okay, shifting to the newborn. Immediate care, APGAR timing.
1 to 5 minutes after birth. Normal score we want to see is 8 to 10.
Normal newborn vitals.
Pulse, 120 to 160 BPM, respirations. 30 to 60 per minute, often irregular pattern is normal.
Yeah.
Temp, axillary, 97.8 to 99 Fahrenheit. First temp might be rectal to check patency. Signs of respiratory distress.
Grunting, nasal flaring, retractions, chest pulling in. Cardiac distress. If heart rate is under 100 BPM, start CPR.
Priorities are ABCs, always. But right after that, thermoregulation is critically important. Newborns lose heat fast.
Best way to keep them warm.
Skin-to-skin contact with mom is great. Radiant warmer if needed. And if the baby's temp does drop, do a glucose check immediately.
Why glucose?
Because trying to generate heat burns through their glucose stores very quickly. Hypothermia often leads to hypoglycemia.
Newborn meds, quick review.
Prophylactic stuff, vitamin K shot, clotting, erythromycin eye ointment, eyes, hepatitis B vaccine first dose.
Labs. What's the most critical one?
PKU blood test, absolutely vital, done after the first 24 hours of feeding. Screens for several serious metabolic errors, plus sickle cell, congenital hypothyroidism. Early detection is key. Also, hearing screen, maybe bilirubin check reflexes, sucking, rooting, moro, etc.
Terminology. Acrocynosis.
Blue hands and feet.
Yeah.
Can be normal initially, especially if cold, as long as the trunk is pink. Should resolve.
But what's not normal blue?
Circumoral cyanosis. Blue around the lips or mouth. That central cyanosis concerning indicates poor oxygenation. Not normal.
Head shape things. Molding.
Molding is just the overlapping of skull bones to fit through the birth canal. Normal. Resolves in a few days. Cephalohematoma.
That's different.
Right. Blood collected under the scalp periosteum. Doesn't cross suture lines. Not usually dangerous itself, but it puts the baby at higher risk for jaundice.
Why the jaundice risk?
Because as that trapped blood breaks down, it releases bilirubin. Jaundice is the yellowing from excess bilirubin. Untreated, severe jaundice can lead to kernicterus.
Kernicterus is
Brain damage from bilirubin buildup. Irreversible neurological problems. That's why we monitor bilirubin closely. Normals are roughly less than 6 on day 0, rising maybe 1 point per day, up to around 12 by day 5.
How do we help get rid of bilirubin?
Feeding. Frequent feeding helps move the bowels, and bilirubin is excreted in the stool. That first dark, terry stool is meconium.
Feeding frequency guidelines.
Breastfeeding, every 2–3 hours. Formula. Usually every 3 to 4 hours. Don't let them go too long.
What about low blood sugar, hypoglycemia?
Concerning if blood glucose is below 30 in the first 72 hours. Intervention is feed the baby breast milk or formula. If too lethargic to feed or glucose stays low, they might need IV glucose.
SIDS prevention. Must know for the exam.
Absolutely. Baby sleeps on their back. Supine position, no co-sleeping in the parent's bed. Use their own crib or bassinet, firm mattress, no loose bedding or toys.
Bathing and cord care.
Bathing is usually delayed a bit for thermoregulation. When done, it's under a radiant warmer. Cord care, keep it clean and dry. Fold the diaper underneath the cord stump, expose it to air. Watch for infection signs, redness, drainage, foul odor.
Circumcision care.
Monitor for bleeding, signs of infection. Apply petroleum jelly generously to the site with each diaper change to prevent sticking.
Okay, last push. Quick facts on congenital conditions and sexuality.
Let's do it. Down syndrome, that's trisomy 21, big risk factor. Advanced maternal age over 35.
Key physical characteristics.
Low reset ears, flattened nasal bridge, which increases risk for obstructive sleep apnea. Also, the single transverse palmar crease, the simian crease. High risk for cardiac defects and leukemia, so they need screening, like a CBC.
Next, cerebral palsy, CP.
Defined as non-progressive abnormal brain or motor function. It doesn't get worse, but the damage is done.
Caused by.
Often hypoxia around birth, infections like sepsis, exposure to toxins, or, importantly, severe kernicterus from untreated jaundice. Note, maternal age is not considered a risk factor for CP itself.
Nursing considerations for CP.
High aspiration risk due to dysphagia, swallowing difficulty, prone to UTIs. Definite fall risk depending on severity. Meds often include baclofen, a muscle relaxant, and maybe anticholinergics to help manage secretions.
Failure to thrive.
Simply put, decreased growth, falling below the standard growth curve. Interventions are focused. Daily weights, meticulous food logs, maybe supplemental feeding like NG or G-tube if needed.
All right, lightning round. Sexuality, quick facts. Erectile dysfunction.
Risk factors. Age over 65, heavy smoking, pack a day or more, BMI over 40. PAVO is basically reduced blood flow perfusion issue. Critical point. An erection lasting longer than 4 hours is a medical emergency. Priapism needs immediate attention.
Menopause. Diagnosis.
Requires 1 full year with no menstrual cycle. Key health teaching. Encourage weight-bearing exercises, walking, lifting weights, not swimming, because of the high risk of osteoporosis. Got to stress those bones safely.
Birth control facts.
Antibiotics can reduce the effectiveness of hormonal birth control pills. Always advise using a backup method, like condoms, while on antibiotics and for a short time after. And definitely know this, breastfeeding is not a reliable form of birth control. Ovulation can return before periods do.
Quick STI points.
Gonorrhea. Suspected if you see purulent pus-like discharge. If someone tests positive for gonorrhea, you must also test for chlamydia. They often travel together. Syphilis can be sneaky. If untreated, later stages can cause severe neuroproblems, including dementia.
Wow. We covered a mountain of information there, from meds and labor stages all the way through BBS, newborn care, and those key conditions.
We did. It was a dense review. Hopefully hitting these key points helps solidify them for the exam.
So as you head into that test, try to remember the connections. Like we talked about how something treatable like high bilirubin causing jaundice.
If missed or managed poorly, can lead to kernicterus.
That permanent neurological damage.
Yeah, which then becomes a known risk factor for cerebral palsy. Seeing those links that cause and effect across different stages and conditions, it's real clinical understanding. You've got this. Good luck.